Good afternoon and welcome everyone to our information and support session. My name is Kathleen Helgeson and I'm the coordinator of the Resource Center at the Center for Hope here at our McCharles site. This afternoon, we're joined by JoAnne Zoppa, Theresa Whiteside, and Jodi Hyman. We're here to share their knowledge and answer your questions about managing the potential side effects of chemotherapy treatment. We are very pleased to offer this session with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Red River Métis. Before we continue, there are some basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you have a question at any time during our discussion, just click on the Q&A icon on your screen and type your question. You can also choose to ask that question anonymously by clicking the Send Anonymously box before you tap on the Send button. My coworker Ellie is also here off screen and will be helping manage your questions as they come in. If you have a technical concern or another comment, you can also share that with Ellie through the Q&A. It's my pleasure to now introduce our guests. Jodi Hyman is the nurse educator for the Systemic Therapy and Community Oncology programs. She has been an oncology nurse for over 30 years and, in her own words, loves her chosen profession. Theresa Whiteside has been the clinical resource nurse for systemic therapy for the last 10 years. She is actively involved in the day-to-day administration of systemic therapy and interacts with patients and her staff on a daily basis. And JoAnne Zoppa would say that she's been at Cancer Care far too long to say out loud. She has worked in the treatment rooms at all 4 sites and in various disease site clinics. She is currently the clinical resource nurse for the Victoria and Grace Hospital Cancer Care sites. Welcome. Thank you all for joining us today.
Thanks, Kathleen.
Thank you.
We're going to start with Jodi, and we're going to be asking each of you some questions, and we're inviting our attendees, our guests in the audience, to also type in their questions for you today. So I've often heard this term systemic therapy being used instead of chemotherapy or including chemotherapy. Can you explain a little bit what that refers to?
Sure. I just want to see, which screen are people seeing? Just out of curiosity, do you see where it says agenda, or what are people actually seeing?
Agenda.
Okay. Agenda.
Yeah.
Okay, I'm going to answer your question in just 1 second, Kathleen, but I did
Sure.
prepare a couple slides. So I'm just going to switch over these presenters here. And then do you see a title page that says chemotherapy side effects?
Yes. We
do. Great. So I realize that Kathleen just asked the question about the different kinds of chemotherapy, but I'm just going to quickly go through a couple things that we're going to go to coincide with the questions. And that's going to be the chemo confusion, which will address your first question, why side effects occur, common myths, and then some questions and answers. So the chemo confusion. So let me just see. Systemic therapy. So systemic therapy really refers to anything that is going through your body. So if you look at something like surgery, for example, surgery just works on the area in which the operation is happening. Systemic therapy could be, if you imagine even a Tylenol, if we make it quite simple, you take the Tylenol and then the effects of the Tylenol go through your whole body. So that is what systemic therapy means. So, and then it says who basically the different kinds of systemic therapy. So many people call everything chemotherapy. So that's what we traditionally know it as. And that's what was given for many, many years and is still currently given to be able to fight cancer. But as we've been able to progress, we have some different kinds of drugs and they also fight the cancer, but they're not actual to be chemotherapy. To actually be chemotherapy, it needs to destroy the innards or the DNA inside of the cell. And then from that, it's responsible for some of the side effects, especially on those that have fast turnover cells, like our hair or our GI tracts, why people can get sores in their mouth. Then we have something called immunotherapy. Again, it's just a different way in it works. And what happens with that is it enables our own immune system to recognize the cancer and to go ahead and attack the cancer that way. So it's a little bit different. targeted therapy is again another name where we're able to, through sort of modern discoveries, being able to look more closely to see exactly what kind of markers are on our cancer cells. And then we have certain drugs that end in the suffix mab that are able to target those, and they can act on those markers that are attached to the cancer cells. And then thirdly, endocrine therapy. Some people call it hormone therapy, but just so people aren't confused, we never give hormones in cancer. All we do is starve the hormones from the cancer. We know that in prostate and in breast and in some of the gynecological malignancies, so that could be ovarian, uterine, etc., that it's actually either our testosterone, our estrogen, or our progesterone that makes the cancer grow. So by having this kind of therapy, therefore, it is able to block the hormones and starve the cancer, so to speak, of the food.
Okay. So Jodi, just to clarify, today we're going to talking primarily about the side effects related to chemotherapy. I imagine that there's different side effects that are related specifically to immunotherapies or targeted therapies as well.
Yeah. So the side effects have to do with the type of drugs you're having and the way that it reacts. So today we're specifically talking about chemotherapy. The one thing to remember is no two people are the same. Everybody responds differently to their treatment. And so what we do is your cancer team works with you to provide the care that's based on your desires and your wishes. It's a term called patient-centered care. So, but to come back to the chemotherapy question, we know that chemotherapy generally exerts its effects on cells that are rapidly dividing. So that would be stuff like our hair, our mouths, nausea, our GI tract, so people can get diarrhea. But again, no two people are the same, and different side effects go with very specific drugs. So, not all drugs will cause nausea and vomiting, and not all drugs will cause hair loss. But why I put this last statement in the slide was to remember that discuss with your team because your team will be able to go through the side effects that are specific to the medications that you're having. There's tons of different drugs, so it's really quite hard, Kathleen, to narrow down to some very specific side effects. One side
Mhm.
effect that is worth mentioning, though, is that we know with chemotherapy, chemotherapy does weaken our immune system. So then people are more at risk of getting an infection. Okay, so it's very important that people know the signs of an infection, which is a temperature above 38 degrees, and then know exactly what they're meant to do if they do have an infection, because the treatment is antibiotics.
Okay. So do people have a choice, like when we talk about patient-centered care, can they say, well, I don't want to be on this type of treatment. I'm experiencing too many side effects. I want you to switch me over to something else. Do they have that choice?
Of course they do. So 100%. The idea is that your cancer team is able to work with you to find out what your wishes are, what your goals are, and then they'll tailor something that works best to suit you, suit how you feel, and suit what you're trying to do.
Mhm. So the chemotherapy itself, does it have like potentially more side effects than other types of treatment?
Not necessarily. All treatment has side effects, and we know that sometimes people will ask, is this a weak chemo or a strong chemo? All the chemotherapy is pretty much the same, but what happens is they have different side effect profiles. So you can't necessarily say this one is stronger than that one. So we know if people have, say, maybe heart disease, there might be some drugs that they can't have because they already have heart disease, or maybe someone else that doesn't have heart disease would be able to have that drug. So that's sort of how it differs from there.
So there are a lot of side effects that are related, and why is that? Can you talk a little bit about that?
Sure. So when we kind of talked a bit about the different kinds of treatments, so whether it be a targeted treatment or a chemotherapy, I always like to think of the chemotherapy as the snow plow. So the chemotherapy just blasts everything that's in its way, right? It's not very specific. And so what happens is you have cancer cells as well as healthy cells being targeted, unfortunately, at the same time. And when we destroy some of our healthy cells, that's why we get side effects. If anyone's ever noticed, when you have your treatment, you often have a break in between your doses, usually 2 weeks or 3 weeks. And that's to let the side effects kind of go away a little bit and as well as going away, to allow the healthy cells to recover before you have your next treatment.
When there's sometimes we also hear about people not being able to continue their treatment for even an extended period of time because of blood counts. Can you talk a little bit about that?
Sure. So, as I mentioned initially, we know that one of the very common side effects of chemotherapy is that it weakens people's immune system. So, our immune system is actually made up of blood cells. And so, what we do as health professionals and what your doctors do is they check your blood cells to make sure that you have enough to fight infection. Our body will naturally, once the chemotherapy has injured our infection fighting cells, it will naturally recover with time. And that's why it usually will all be recovered within 2 or 3 weeks. But depending on the type of cancer people have, the type of chemotherapy, your age, a bunch of different things, sometimes it takes a little bit longer. And so, what we need to do is we need to make sure that your infection fighting cells, which are blood cells, predominantly something called white blood cells, are back to their normal state before you have your next treatment. If they're not normal, then we're continuously kind of, I guess, I don't know if this is still a used old adage, but kicking a dog when it's down. So you want your sort of peak to go like this. I don't know if people can see me come back up again, so you're good to go. And again, if we don't wait till recovery, your sort of line continuously goes down and down and down, and we don't give people a chance to get their strength back, to recover, and to build their immune system fighting cells again.
Hmm. So is that neutropenia? Is that what is neutropenia?
So yeah, so that's what's called neutropenia. So our white blood cells or overarching group, and within the white blood cells, we have lots of different kinds of white blood cells. One is called a neutrophil. So a neutrophil is responsible for recognizing and gobbling up bacteria. So I always think of it as sort of like a little bit of like the neutrophils, like a little bit of slime or something, and then you have it there, and it literally engulfs it and gobbles it all up. So that's one that we're particularly interested in, and that's one that's mainly responsible for fighting infection. But we're interested in all of our immune system cells because you need your right hand and your left hand. So even if your neutrophils are normal, if you have other cells that don't work properly, the physician might still want to hold to give you a chance to build up your infection fighting capabilities.
Okay. And what
I
about
would-
anemia? Is that, oh, I'm sorry, JoAnne, go ahead. Yeah.
Go ahead.
yeah, I was just going to add that, and sometimes it can be things like kidney function or liver function that can delay a treatment as well, because we need those organs in our body to clear out the chemotherapy or immune therapy or whatever you're getting. And so we need those to be working well in order to give you your next dose too.
Okay, great. And what about anemia? Is that an issue in continuing care or continuing treatment?
So it can be as well. So the all of our blood cells in adults are made in our hips. It's something called bone marrow, and our bone marrow produce our infection fighting cells, our red blood cells, which is known as hemoglobin, and it carries the oxygen around our body, as well as something called platelets, which help our blood clot. And we know that the chemotherapy decreases the production of all the blood cells. So if someone's hemoglobin is low, so I would say below 100, then they might feel a little bit short of breath. They could be a bit more tired. They could have less of an exercise tolerance. So we monitor that as well. Somebody typically will not have their treatment delayed for a low hemoglobin unless it's extremely low. But what might happen is they might need to have a couple bags of blood to just boost it back up so people feel better.
So I noticed you just brought up your slide about myths, and I mean, now we're in the age where everybody has access to so much information, too much information probably. How do we know what, when we're looking for information about cancer treatment and side effects, how do we know what we're looking at as a credible source?
So for me, I'll answer this and then I'll put it over to my colleagues as well. So for me, there's lots and lots of information. I routinely send people to the Canadian Cancer Society. I think they've done a fantastic job. They have some really, really good information and lots of information, and it's not overwhelming, and you can search lots of things. There's also the Leukemia and Lymphoma Society of Canada. That's another one, a Canadian resource that has lots of really good information. And if you're looking for something even more so, I would ask your healthcare team, please, please, please stay off Reddit and all other sorts of Facebook and all that other kind of garbage, because a lot of that is uneducated opinions and it's not based on fact. And we know that a lot of things are completely untrue. And I actually want to highlight the sugar causes cancer because that's one that comes up a lot. And there's actually no evidence to say that sugar causes cancer. There is evidence to say that basically, if people are obese, that they are at a higher cancer risk because we know that lifestyle factors such as being sedentary, eating lots of processed meat, and being overweight increases your risk of cancer. But as far as a direct correlation between sugar and cancer, that's not true. And then I just put up a few of the other sort of myths. Uh, not all chemotherapy causes nausea and vomiting. And the other one, hair. Hair is drug specific. It has nothing to do with the kind of cancer you have. It has to do with the drugs that we give you. And the other one that's important is oral chemotherapy is just as strong as IV. The drug companies spend a lot of money making it more convenient for patients, but it doesn't mean it's weaker at any level. They can have just as many side effects. It can weaken your immune system just as much. They're just trying to make it easier for people to take. And I'm going to hand over to my colleagues just to say a little bit more.
I think the only thing I would add, Jodi, is that a lot of people have the misconception that the sicker I am from my treatment, the better it's working, and that is also not true. And we can give two people with the same types of cancer the same drugs, and they have very different experiences.
That's good to know.
True.
Thank you, Jodi. I'll turn things over a little bit now to Theresa to talk a little bit about, I guess, one of the myths around is nausea and vomiting. We often see, particularly in movies and television, people going through chemotherapy. They're always in front of the toilet, and so it, how common is this a side effect, and what advances have been made in terms of managing it?
Yeah, well, great advances have been made. I, like Joe, have been doing this for 30 some years. And if I look back on how we treated nausea and vomiting then versus now, we had limited drugs to use, mind you, and we didn't have the experience that we have now. And today, essentially, it's actually rare for people to experience vomiting. Nausea, yes, that I'm not sure we're ever going to get rid of all nausea, but we can manage it. But as far as vomiting goes, I have to say it's rare. It's not very common. If it does happen to, we tend to address it immediately as soon as we know about it and fix it. Today, we use cocktails of antiemetic is how we refer to it, as drugs to prevent nausea and vomiting. And some of them are very specific to the chemo that you get. So if you're getting chemo A and B, you will get this cocktail of pills and IV medications to help prevent nausea and vomiting. So we try and reassure our patients as much as we can that they should not expect to be in the bathroom. And if they are experiencing it, they need to call and let their clinic nurse know or their physician know so that we can fix it. One of the ways that we use now to help fix it, besides more medication, is hydration, is bringing them in for some extra fluids and that, because obviously if they're nauseated or vomiting, they're not keeping up their fluids, which we've learned over time is very important after chemo and during chemo to keep up. So
how much
we'll
would
often
be?
bring them in. Yeah, we say like 1 to 2 liters a day. I often recommend, if people are drinking water bottles, if they drank 1 before lunch and 2 after lunch to bedtime, that's 1.5 liters right there. And that's just water, but you can count soup. tea, coffee, juice, even Jello, popsicles, like anything like that can count as fluid as well.
Is it kind of flushing your body of
Yeah.
the toxins when you're
It's
doing that?
flushing it out. So the chemo works. It works immediately, and then after that, we need our kidneys and to flush it out. We don't need the chemo hanging around for it to work. Like it doesn't work. It starts working immediately, and then we need to flush it out. Keep our kidneys in good shape, and the
Mm.
fluids will make you feel better.
What about any natural remedies for nausea? We often hear about people taking things with ginger. Does
Yeah,
that is it
yeah.
effective?
It's so there's ginger ale. I mean, in the old days they used to
Mm.
have a flat ginger ale to help with nausea. A few people may remember that. There's Gravol with ginger that some people do. I don't know that it's scientifically proven that it helps, but it won't hurt as long as it's within reason.
Okay. And how about just generally trying to keep up with your eating? Because like when people have morning sickness, for example, like eating actually sometimes can help with that nausea. Is that the same?
Well,
Would you say?
that is true with morning sickness. There's a fine line between hunger and nausea. So that's why sometimes having crackers or something. What? After chemo, I would say it's more important to drink than to eat. Keep your fluids up. And then, but I know it stresses a lot of families and people out when their loved one doesn't eat. It
Mm.
and plus, so, but overall, I would say drink first and then eat what you feel comfortable eating. Obviously, stay
Mhm.
away from, spicy foods or heavy foods and that. But, if they only want to eat, mashed potatoes or scrambled eggs or toast and that's
Mm.
fine. Have that. That's fine. The appetite usually comes back after a few days. And only if it doesn't, then you need to contact the healthcare team to let them know that the eating thing isn't coming back at all. But
Okay.
out of the two, I'd prefer patients drink
Drink.
fluids.
Okay, good advice. And we do have some good cookbooks as well in the library here about eating well through,
Oh, yeah.
cancer treatment and eating well through chemotherapy. So
Yeah.
some good resources. Um, the big question for a lot of people is what's going to happen to my hair and hair loss probably, for our patients is one of the most dreaded side effects that they're
Yeah.
that
Yeah.
they're facing.
Yeah.
Does everyone lose their hair?
Mm,
And and is there anything they can do to not
yeah.
lose their hair?
So, no, it's a very distressing event when it does happen. But no, not everybody loses their hair. So it depends on the chemotherapy drugs that they're getting. So the type of chemo they get will determine whether or not they will lose their hair.
Mhm.
And some may only have thinning, but hair loss is when they're going to lose their hair, typically it's all hair, all body hair, eyelashes, eyebrows, everything. So sometimes a little upsetting when people realize they lose all their body hair, not just what they can see.
So is it true that eyebrows and eyelashes grow back sooner?
Well, I can't say I know that they grow back sooner. But I will say if you lose your eyelashes, you need to protect your eyes because
Mm.
now your eyes have lost the ability to filter out little particles or sand or anything that might be blowing. So they would be a little bit more sensitive. Sunglasses or eyewear would be recommended for outside. And
Mm.
but I don't know if Joe or Jodi knows the answer to that. I don't know that they grow back any faster. I don't think so. I think
Mhm.
it's
I
all
don't
about the same.
Yeah.
I I would think it's about the same as well, but you do bring up a great point, Teresa, about, we all think of our eyelashes and eyebrows more of like a beauty type thing. But yeah, I guess if you don't have any, you're going to be that much
Yep,
more at risk of the
yep,
elements,
yep,
especially when it's so dusty
yep.
outside, like in the
Exactly.
fall and
Yep,
stuff,
yep.
or in the spring when we still have all the winter sand on the streets and it's
Hmm.
blowing around.
Yep. True. too. So that's something to keep in mind.
Yeah,
And
I found
how
too that
go ahead, JoAnne.
sometimes people actually lose the hair in their nose, and so they're complaining of a drippy
Oh,
nose all the time.
yes, yeah,
And
yeah,
so
yeah,
though
yeah,
that's what our nose hairs are actually functional. They're not.
yeah,
Just problematic.
yeah,
Yeah.
yeah, yeah, yeah.
So in terms of like the length of time it takes for people for their hair to grow back, I have heard people talk about their hair growing back in between their chemotherapy sessions even. Is that like, can it grow back that quickly?
So it starts for some, it starts to grow back, like some peach fuzz really
Yeah.
is what it looks like. And again, it depends. It also depends on like how much hair you start with.
Hmm.
So a full head of hair might very well, all of it may not fall out after the first session. It might take, more than one. Many people find it very distressing, especially if they have long hair, like you, Kathleen, to find hair coming out in bits and pieces or clumps, so many choose to shave their hair off
Hmm.
before they actually lose it all. And once they do, they find it's just neater and easier, and they sort of, it's inevitable for some. So that's what many do.
Yeah. And we do have a wonderful program here, the Guardian Angel Caring Room, that lends people a wig and
Yeah,
4 pieces of
yeah,
headwear. It's a great
Mhm.
program.
it
And
is.
if people aren't aware of it, to definitely drop by the resource center and we can fill you in about that. But also the Look Good Feel Better program, who we partner with, they
Hmm.
run workshops
Hmm.
monthly to teach you about skincare and makeup and headwear as well. And they have workshops for men and teenagers too. So yeah, it's a great resource as well.
just to
Um,
add one
yeah.
thing, if I may. So people's hair will start to fall out usually about 7 to 10 days after their treatment. So often people will be having a shower, maybe they're washing their hair, towel drying, brushing, whatever, and it will tend to come out in clumps. The other thing to note about shaving your head, if people do choose to shave their head, I think it's preferable to go to a number one versus bald, because if you're completely bald, you could accidentally nick yourself. Again, with that
Yeah.
weakened immune system, it could be at risk of infection. And if you are just definitely want to go bald, you're absolutely set on it, please go to a hairdresser, because although we think it's really easy to shave our heads, if you've never done it before, we don't want people with little nick marks all over themselves because it's an
Mhm.
infection risk.
Yeah.
Definitely. So we often receive questions here in the caring room about cold caps, something that maybe other places in the States, other cancer centers have for people to use at a cost, of course. Have you guys experienced anyone using cold caps? Does it help for hair loss?
So we've had a few over the years, and it's probably close to, I'd say 15, 20 years ago when we first saw cold caps coming. And I have to tell you, they've come in and out of vogue since then, for numerous reasons. It's cumbersome. You need somebody else with you. For the cold cap, they have two different kinds. They can either you wear a cap and it has tubes through it, and cool water actually circulates, but you have to have a machine with you that you have to bring with you. You have to rent it. You have to have it on before chemo and then up to 3 to 5 hours after chemo. So that is actually, a cold cap. They also have another type, which I've seen here recently, where they pack a cap in dry ice and they change it every 25 minutes, every 20 to 25 minutes. So that you definitely need somebody else with you to help monitor the temperature, to change the caps, take it out of the dry ice, put it on. You have to wear protective gel around your head so that you're not burning your skin from the dry ice. The machine you rent, and the dry ice you pay. Well, technically it doesn't come with the machine. There's one center in Winnipeg that supplies dry ice, but you have to pay for it. So
like quite an
there is a cost
undertaking.
factor. You have to have somebody with you. You change those caps every 20 or 25 minutes. If you live further away, you stop on the side of the road and have somebody help you change your cap. It's so, and overall, I would say for those that started out with a lot of hair, um, they they felt they lost. They didn't lose all of it, but again, it depends on their disease and the chemo drugs that they're getting. So
Right.
certain drugs, they're bound to lose it no matter what. So this may help slow it down a little bit. There's no guarantee.
No.
There's no guarantee. And really, it is very drug specific as well. And so the idea behind it is if it's cold, it will constrict or make the blood vessels close to your hair follicles so small that the chemo can't get to it. So the problem with that is the chemo often has a very long, what we refer to as a half-life. So 24 hours from now, 30 hours from now, there's still some chemo circulating. So that's why, and you can't wear a cold cap for, 2 or 3 days. So
Yeah.
I'd say the jury is out. It's unfortunately, it's not 100% guarantee that you will not lose your hair.
Okay. Yeah, thank you, Theresa. What about changes to nails? Sometimes people have really complained about their nails hurting and
Yep.
lifting. What
Yep.
is the
It's
approach towards dealing with that?
so that again, predominantly drug specific. Not everybody will have that. They are painful. It can be very painful. So really, we would recommend keep your nails short. Unfortunately, probably better to keep them clear. No nail, like don't, no nail, like gels or acrylics going on. Do not let anybody really do cuticle cutting. Cuticles are very prone to, especially when we don't have a lot of cells fighting bacteria after the chemo. So our cuticles, as it is, anybody who's had like a hangnail, and sometimes they get infected in that, patients on chemo, a lot more prone to it. So I'd recommend no major manicures. Keep your nails short, clear nail polish. And other than that, there's not much you can do for the nails. They're going to come off. They'll grow back. They take a little while. They do grow back, but it can be painful.
Is there any truth to soaking your hands in warm water and vinegar to help with any?
I haven't really heard them. Not the vinegar. I would say, warm. I'd say Epsom salts over, vinegar, just or nothing, or a little salt water, just keep them clean. Vinegar, I think, is a little too harsh.
You think so? It would
Not a
sting.
good idea. I don't. Yeah, I would
Yeah.
say no vinegar personally.
I've,
Or
I've,
put a little soap, like even just a little liquid soap, like just to keep them moisture.
Antibacterial.
Yeah.
I've never heard of vinegar and water
Yeah.
either. I mean, this is a new one,
You
so
can add it to your myths.
Yeah.
yeah,
Yeah.
no, soap and water.
Okay.
Yeah.
We have a question from somebody that has had foot neuropathy and felt that it was maybe exacerbated by chemotherapy. They felt that it had been brought on from liver failure in 2020. So just asking if there's anything they can do. And could you explain a little bit, Theresa, what neuropathy is, why it happens?
Yeah. So neuropathy is nerve damage and from chemo. Certain types of chemo, not all chemo. We know certain ones are worse than others. And it's nerve damage. And so it's something that needs to be monitored in clinic. So certain, questions that we'll often ask are, can you button your buttons? Can you pick up like a dime or a quarter or a coin? Do you feel like, and the sensation is the issue. Toes and fingers are at risk. So walking and, bumping into something, and stubbing your toe, you may not feel it. So it's like a diabetic who has to check their feet for that. So it needs to be monitored because there's certain drugs that they'll have to cut the dose down on the drug because we're doing more damage than good. And there are some medications that they can give to help with it during it, but eventually it will come back for the most part. It will return, but it will take time. It takes a long time, actually.
Okay. Let's switch things over to JoAnne. Wanted to ask you a little bit about people's having allergic reactions to chemotherapy. I've sometimes had people say that they had to go off some chemotherapy because they were actually having a reaction to it. Can you tell us what the difference is between that and then somebody having a side effect like a rash?
Okay. Sure. Well, I would think that, or I would say that infusion-related reactions are probably much more common than actual allergic reactions. Um, and the symptoms can look very similar, all the way from having breathing issues, shortness of breath, to low blood pressure, so feeling dizzy, or sudden back pain, or sudden nausea, rashes, getting very flushed in the face. And just so you know that we're well aware that there are a lot of our drugs that can cause these infusion-related reactions more often than others. So sometimes we will ask people to take medications at home before they come to the treatment room to prevent these reactions. Sometimes we'll have the nurses in the treatment room administer them beforehand to help prevent. And when they do occur, we do have what's called our hypersensitivity protocol, and it's followed in all of our treatment rooms. So it's very specific, if this, and this happens. And I mean, the first thing we do is stop the drug. And then we give medications to help alleviate some of those side effects. If the patient responds nicely and those side effects go away completely after half an hour or so, we may start the drug again, probably at a slower rate. Okay. And then we always let the clinic team know that that has happened in the treatment rooms. And often it's up to the medical oncologist whether they think that this is actually just related to the infusion and maybe we need to slow it down, maybe we need to give a few more pre-meds, or is this actually an allergy? And we also have an allergist clinic here at Cancer Care, so sometimes we'll send patients there. And really the best way to tell if there is if somebody's having a true allergic response is with a skin test, and also we'll do a blood test kind of from about 1 to 3 hours after they've had that reaction to see if some of their blood levels have increased, and that can help the allergist to as well determine if this was actually an allergy. One of the other things we can do is if we think it is all related to kind of how we're giving it, is we have desensitization protocols, and so we may give just the tiniest little 1% of the drug over an hour, and then we might increase it to 10%, like a 10% of the drug in a bag, and give that over the next hour, and then slowly build our way up so that the patient's tolerating. And often we can get the full dose into the patient, and they can get the benefit of the medication.
So are rashes in general a common side effect of chemotherapy, just a skin rash?
Just a skin rash can be, yeah, absolutely. And probably antihistamines, just over the counter, like a Claritin or Reactin, is your best defense against those. But always you should be talking to the clinic team before you're taking that. Sometimes some of the docs will prescribe a hydrocortisone cream as well to help reduce some of the itchiness that can be associated with a rash.
Yeah, because itchiness can really interfere with quality of life as well. I mean, just if you have an insane amount of itching going on, like we've had some patients talk about just the amount of itching that was related to, or the side effect of one of the drugs that they were taking.
Right. Yeah, absolutely.
Yeah. So that wouldn't be an allergic reaction, that would just be an itchy rash.
Well, you know what? It's always important to, because sometimes these reactions can occur right in our treatment room while we're giving the medication, but sometimes a reaction can be little bit delayed, and having a rash is what we would consider a delayed reaction, and so the clinic team should be made aware of that. So even if it's kind of making you crazy in the middle of the night and you have some reactant at home, you take it, you should probably still be calling your clinic team and letting them know that it happened. And they may want to add something to your next infusion to help prevent it.
Okay, great. Can we talk a little bit about cancer fatigue? This is a common side effect that people often experience through treatment, but is it related to the treatment itself, or is it cancer itself that causes the fatigue?
Well, if we could determine exactly what it was related to, we'd hit the money shot. I think it's definitely a combination of things. Um, sometimes it's the drugs. We are putting chemical in your body, and so your body is using energy to process it, and your liver's working to kind of clear your blood and that kind of thing. You're also probably not sleeping quite as well, perhaps not eating quite as well, and even not getting the same exercise that you used to can can alter patients' sleep patterns. And I think just the mental toll of being given a cancer diagnosis probably weighs heavily on patients.
To that.
I often
go ahead.
I was just going to say, I often tell people, when they've kind of completed their treatments, I say, it took us 6 months to make you feel this tired and this far from your baseline. So I would give yourself at least another 6 months. And you might not get quite back up to the 100% of that baseline that you started at before you got your diagnosis. So, give yourself some grace and time.
Yeah. And would you say that would be the same for brain fog? Often it used to be called chemo brain. Would you say it's also a combination of everything going on, not just the treatment itself?
Absolutely. Yeah. Yeah, I think so. I don't know if Jodi and Theresa have anything to add to that, but
yeah, no, absolutely.
I'm going to add a little bit about the fatigue,
sure.
if that's okay. So we know that around the world, this is a #1 problem for people affected by cancer. And so they've done lots and lots of research about cancer-related fatigue. And what they found is that it's different from normal fatigue that, say, maybe the four of us might get. So sometimes if you have a nap, you don't feel better. So what they have done is they've done lots of different trials, and the best thing to do to combat cancer and treatment-related fatigue is little bits of light exercise. So, and it can be light, maybe 5 minutes, 3 or 4 times a day. You're not in training. You just need to get your body moving, that blood flowing. I always say to people, if you fall asleep in the chair, so be it in front of the TV. But if you're getting into bed, you really shouldn't be getting into bed during the day for more than about 1 hour. And then you should be trying to get up. You should try and sit up. If people lie down all the time, then when they get up, they often get dizzy. Your family may want to do every single thing for you. It's a nice gesture, but it's not actually helpful. So you need to try and keep your baseline as sort of where you normally are with a little bit of light movement and light exercise. And same with visitors. If you have to go to Sobeys, Safeway, wherever, and make a tray of dainties and snacks for your visitors, and then you're exhausted, they're the wrong visitors. So they can come once you're feeling better.
Yeah, I often encourage patients just to walk to the end of the driveway after every meal. And just that bit of movement also helps our GI system work better too. And that improves everything.
A good
Actually,
test is if you've done something, say you do a new activity to check out. If you're completely exhausted and have to get into bed for 2 hours, you've done too much. It should be that you're doing some light exercise. Maybe you
Mhm.
feel tired, so you sit down, you relax, and you feel a little bit better and then get up again. So you just want to be able to find that nice balance. And even if there's a day where you don't want to do any exercise because you just feel too exhausted or not good, please, please, please go and sit in the chair or on the couch. Don't lie down all the time. It's really not good for us.
thank you. Good advice again. It's now time for the firing line, I guess, because we've got some questions that I'd like to ask from our audience. So one question here about constipation. Any recommendations for how to cope with that?
There's lots. You know what? And it's a very, very common problem, very
Mhm.
common. So, ideally, if anybody is taking pain medicine, narcotics, they're known. Start on something immediately, a stool softener and a laxative. Now, some of this is trial and error because there are a few people who are not bothered by pain medicines and narcotics. But we're going to figure, you start out thinking that you will. So you want to get ahead of it if you can. And then you figure out a little regime that works for you. So if you're taking something for pain, you're taking something for your bowels. Many, unfortunately, end up in a position where they need to come into urgent care. We have an urgent care at Cancer Care. We see a lot of patients for constipation. On our website, I believe we have recipes for constipation, certain foods and that to have, and tips, increasing your fluids and um, watching, your diet and things like that. But really, the main thing I would say, get on top of it as soon as you can and call your clinic. Don't let it go 6, 7 days too long.
Mhm.
It's too
And
long. You can end up in trouble.
and one of our anti-nauseants that we give as well, something called ondansetron. They're yellow oval pills. Those are constipating as well.
Constipating.
So even if you're not on any narcotics,
Hmm.
those will do it.
Yep.
No.
Yeah. And
Is heart
keeping up the fluids too.
And keep up
Yeah.
with
Yeah.
fluids. Yeah.
Is heartburn a common chemo side effect?
So I was going to say, not necessarily
Chemo.
chemotherapy, but
Right.
one of the anti-nausea medications we give is something called dexamethasone, and it's a steroid, and that causes heartburn. So it is recommended that people take that with food, and people take it in the morning 'cause it can also keep you awake at night. So I would suggest try taking it with a meal, not just like one cracker if you're getting heartburn. If it continues, talk to the doctor because they might put you on just a medication to help with that, just as an as needed basis.
Okay. This might be more of a dietitian question. I probably would want to refer this person to one of our dietitians to ask, but they just talked about the question about craving salty foods and eating red meat a couple times a week. Is that okay? That sounds, and also asking about eating soybeans and having triple negative tumors. That sounds like maybe a good question for a dietitian.
I mean, I think we
Um,
could probably also
Yeah.
Sure,
tackle
go ahead.
that.
Yeah, take a shot. Yeah.
Could
Yeah, if
take a
you're,
shot. I'd
yeah,
say
for sure.
red meat, nothing wrong with it. It's full of protein. As long as they're not overdoing it. Personally, I would say red meat, that's what they want to eat. Uh, that will not hurt them at all.
I think
I,
everything
I,
in moderation, right?
Exactly.
yeah, and
Exactly.
I agree. I think that the stigma of red meat isn't necessarily the red meat; it's the fatty red meat. So, a nice lean piece of red meat is not the same as a piece of bacon, and it's not the same as a piece of bologna. So, if you are having, some red meat that doesn't have tons of fat in it, I think that's fine. And that, I mean, I'm not. So typically, people that have a triple negative cancer means that they are not susceptible to hormones. Soy has something called pseudoestrogen. So it's a type of estrogen in soy. If you have a cancer that is not susceptible to estrogen, it's not going to make any difference if you eat it. But you can also check with your physician just to be sure, just to make sure that there's no confusion anywhere.
Another question related to diarrhea and constipation, saying, is it like seesawing back and forth between taking drugs for constipation, then getting diarrhea, taking drugs for diarrhea? Just asking, should you just kind of let things run their course and then let nature kind of adjust itself, or would you recommend that they still take medications for these things?
I would say if you're kind of going back and forth between the two, you're probably taking a little bit too much laxatives and a little bit too much Imodium. It is a really fine line, and everybody's GI tract is different, I think, and patients just have to just kind of really keep track of what they're taking and also what they're eating, because that can affect how your bowel works. So it's just it is a bit of a balancing act for sure.
Okay.
And cheese is quite constipating. I don't know if everybody knows that, because I know a lot of people love cheese. And so cheese can sometimes, and it's not hard on your mouth if you have a bit of a sore mouth. Cheese is very constipating as well from a diet perspective.
Okay. There's a couple more questions around that. It sounds like that's a common side effect people have had, the diarrhea, constipation. Somebody else mentions about using Restoralax and even a colonoscopy bowel cleansing product. So that's sort of like when you drink and you clean out your. Are those recommended for somebody that's doing treatment, that they would take something like that for constipation?
So Restoralax, we recommend. Absolutely. Nothing wrong with that at all. The colonoscopy preps, no, there's no reason, and nobody should be taking that unless they're going for a colonoscopy.
Okay.
It can be detrimental, right?
Yep.
Because you can lose a lot of your electrolytes and minerals. So if you're doing anything more than sort of a Restoralax or something, or you're doing anything that you sort of heard of or a little bit alternative, please check with your physician and your cancer team first, because it may cause more harm than anything else.
Someone else mentioned that they had been on a feeding tube for 9 months, asking whether that would be worse in regards to nausea.
Again, dependent. And I know if people feed at night, sometimes people can be nauseous. It depends on the type of feed you're having, the speed you're having. I mean, if you imagine drinking a milkshake and then laying down all the time, you might have increased nausea. It's just, some of it we can say for sure. Some of it is just situationally dependent, depending on the type of cancer, depending what kind of treatment you have. Where did you have radiation? Where did you have radiation? There's lots of different factors that could play into it.
Is hand and foot syndrome a side effect of chemotherapy?
So there are a few drugs that will cause redness and painful at times, yes, palms of the hands and soles of the feet.
It's fluorouracil and capecitabine are the worst ones.
Predominantly, yeah.
The drugs that affect that. So this patient had mentioned that they found a magnesium balm helps their, you've heard of that being used to be effective for that?
If it works for them, I assume that's a topical that they're putting on. Yeah, so if that is, I don't think it's going to hurt them.
Okay. Next question. I'm just trying to get them all in here. So organ function testing prior to chemo, is there organ function testing done routinely?
Yeah, absolutely.
Is an echocardiogram done prior to chemo?
To some treatments, because we know that the drug can affect the heart function, and in those sometimes we just need to do one before we start as a baseline, so we know where the person's at before we've given any drug. And then if the person's going to be on that drug for an extended length of time, we would probably do it. Usually it's recommended every 3 months for the one medication I'm sorry.
You're in demand. Yeah, so just in terms of the electrocardiogram, that would be in relation to if it was a specific drug that they were going to be taking.
Yeah, an echocardiogram or an
Echocardiogram, sorry. Yeah.
actually either or. Sometimes
Okay.
sometimes we need to do an EKG, sometimes we need to do an echo.
Okay. One other question about, is it safe to drink electrolytes to help with nausea and rehydration?
I find we don't recommend it. You shouldn't, you got to be careful you don't overdo it with those, and really just keep up. Really, water is the best thing to drink.
Okay.
I think, we don't recommend those high electrolyte replacements. You shouldn't be. There's certain drugs we know you'll lose some electrolytes. We monitor those, and we replace them intravenously, really. So
Okay.
I don't think. No.
How about tips for a dry mouth?
So I think that they say kind of sour candies, some pineapple. You can buy artificial saliva that actually doesn't taste too bad, and you can buy some different biotine swabs for that. If you have a very dry mouth, it's really important to make sure that you see your dentist on a regular basis and brush your teeth because we know that saliva protects us from getting cavities. The other thing is you want to make sure that you keep your lips moist so your lips don't get too dry and chapped.
Okay. Another question about somebody experiencing joint pain and cracking sounds when they're exercising. Is joint pain related to the chemotherapy? Is that a side effect?
Sometimes it can be related
Yeah.
to the chemotherapy,
Yeah.
and sometimes it's to the medications that we will give afterwards to help boost the bone marrow to work.
Okay.
So yeah, definitely like bony aches and some joint pain for sure.
Okay.
And sometimes as well, we don't necessarily know 100% because we're all probably aging at the same time. So if somebody has a little bit of arthritis, it may actually have nothing to do with their treatment, and it might just be a natural ache and a pain.
Okay. Yeah. And what about nosebleeds? Is that a side effect from chemo? Is it dryness that could cause that?
So
Well, sorry, Jodi, go
go
ahead.
ahead. Oh,
No,
I
I
was
was
just
just going to say it's dryness. It could absolutely be, but it could also be the fact that your platelet count, that's what helps our blood to clot. Platelet count is too low. And especially if the nosebleed doesn't stop, you need to call clinic.
Okay. How about a metallic taste in your mouth?
So a metallic taste to your mouth can often be from one class of drug called platinums. So they're made out of heavy metals. So that'd be something called carboplatinum, cisplatinum, and oxaliplatin. And what they suggest is don't eat foods or drink drinks that are touching tin because it can accentuate that tinny taste. It's a known side effect. So, for example, if you're going to have a Diet Coke or a ginger ale, drink it in a bottle instead of out of a can. If you're making baked potatoes, maybe put no tin foil on them. Store your food with like saran wrap, not tin foil because that tends to make it worse.
Okay. Good to
But
know.
it's just symptom management. It's not harmful, the metallic taste. It's just very inconvenient because it's not
Mhm.
very nice, but it's not actually bringing you any harm.
Okay. Somebody had a question about a period after chemotherapy where they may be more prone to infection or illness. Is there a certain period of time where after someone's gone through a treatment that you're saying you should be extra careful?
Oh, yeah, absolutely. Usually about a week after treatment, and for a week is when your blood counts, your neutrophils are likely at their lowest. And so those are our infection fighters. So I would say, good hand washing is your first defense. If you're going out in public and, now there's lots of people coughing and sneezing, so it might not be a bad idea for you to wear a mask. It's not absolutely necessary. I think that's probably a personal choice. But if you've got somebody that wants to come over and visit you that's actively sneezing or coughing, I would suggest that they,
So no,
yeah, say
I
no.
agree.
They
At
can come
at
again another week.
yeah,
Mhm.
at any time. If someone is
Yeah.
actively sneezing and coughing
Yeah.
at any time during your treatment, they should not come over.
No.
That's true.
No. No.
There's a couple of questions remaining, but they're not related specifically to side effects for chemotherapy. So if I haven't asked your question, please reach out to me at the Resource Center. I'll get Allie to maybe put up my email so that you can reach me and so that I can get those answers or questions answered for you. Also, Allie has listed in the Q&A or the chat, she's put in the number for our dietitians. So if you have more specific questions about eating well through cancer treatment, that you could reach out and speak to one of our dietitians. I'd really like to take a moment just to thank you guys for answering all these questions, a kind of a flurry of questions, which I'm really happy to see and happy for all of you who joined us today. It was, I hope it was as informative and helpful for you as it was for me. But your feedback is really important to us. So if you could take time to complete our survey, which will appear at the end of the session, we'd really appreciate it. It helps us plan for future sessions. And I'd also invite you all to join us next month. February 12th, we're hosting a webinar about complementary therapy. So some of the questions you asked today may actually kind of carry over to what we've talked about and touched on with this webinar. So thank you again, Jodi, Theresa, JoAnne. Thank you so much for your time, for helping us plan this and for sharing your knowledge. Okay,
Thank you so much, Kathleen.
Thank you
Thanks
for
for having
having
us.
us.
Take
Okay.
care, everyone.
Bye
Have a good
bye.
night.
Bye-bye.
Bye-bye now.
Bye.
Bye.